Hello, everybody. I am Cindy Gavin, CEO and co-founder of Let's Win Pancreatic Cancer, and I have the honor of welcoming you to our pancreatic cancer webinar series, Let's Learn. Today, I have the privilege of introducing you to three wonderful panelists, Dr. Ray Wadlow, a patient advocate, Andy Lyons, and our moderator and Let's Win board member, Juan Pellerano-Rendon. Before we get started, I want to tell you a little bit about Let's Win. Let's Win was born in 2016 as the go-to resource to guide patients and caregivers with vital information for better outcomes. Everything that Let's Win shares is both medically vetted and available in both English and Spanish. Over the years, we have developed a wealth of educational materials and have over 900 stories, which include the work of over 220 medical professionals from over 110 institutions. And what I love most is that we've also shared the work and stories from over 220 patients willing to share their stories to empower other patients. And we have a video series with over 90 videos of 5+ year long-term survivors. On average, we see over 35,000 users to the platform. Everything is easily accessible, easy to understand, and we want to make sure that no patient or family experiences a journey with pancreatic cancer alone. Over the years, we have had the honor of partnering with the National Alliance for Hispanic Health, and I am proud to introduce my co-partner, Marcela Gaitan from the National Alliance for Hispanic Health. Marcela, take it away.
Thank you very much, Cindy. Hello, everyone. Thank you very much for participating in our webinar today. My name is Marcela Gaitan, and I work at the National Alliance for Hispanic Health. We're a nonprofit public health organization. We work with community-based organizations around the country that provide services to over 15 million people, Hispanics, in the United States. We work to ensure that health incorporates the best of the science, culture, and community. I'm also the program director for the Nuestras, Adelante network initiative, which is a program funded by CDC to address commercial tobacco use prevention and cancer prevention, with particular focus on Hispanic communities, but also looking at the social determinants of health. We have had the pleasure of working with Let's Win for numbers of years to get information, add information to our community members so they can make informed decisions when they have to have family members or their own diagnosis with pancreatic cancer. And now I have the pleasure of introducing our moderator for today. Next slide, please.
Hello, everyone.
Okay. So, Juan,
Yes.
introduce you first. I'd like to introduce our moderator for today, Juan Pellerano-Rendon, who is a first-generation American and of Dominican and Colombian descent. He received his degree in advertising, marketing, and sports administration from the University of Miami. In his career, Juan has focused his career in the marketing and tech sectors, and he's currently chief marketing officer at SWAP. Juan is deeply passionate about pancreatic cancer. He joined his mother, Dr. Marta Rendon, on the front lines in her own fight against pancreatic cancer for 4 years. Juan now carries on the fight as a member of the board of directors of Let's Win. Juan, the podium is yours.
Thank you so much, Marcela, and thank you all for joining this webinar today. This is a super important topic to discuss. As Marcela mentioned, I was directly impacted by this with my mother, and excited to carry on that fight with you all and ensure that through Let's Win are, continues to be your guide to hope and action. So with this webinar specifically, we want to focus on the risk factors, what questions to ask your doctor, what's right for you. Obviously, the treatment is very individual, so we want to make sure that it's tailored to your needs. The importance of early screening. This is something that, as we talk about it through Let's Win, there's a lot of advancements here, and we're very excited to discuss more about early screening and how important it can be. And of course, work with your physician to make informed decisions and not hesitate to ask questions. In this process, it's really important, even if it's for yourself or for a loved one, to be your own advocate. And we encourage that, and it's the best way to get to the best treatment. So if we go to the next slide, we can talk a little bit about people who have been impacted by pancreatic cancer. Congressman John Lewis and Aretha Franklin most recently, as well as Ruth Bader Ginsburg and Alex Trebek. We know that this is increasingly a cause of death amongst adults, and we are doing our best to provide that guide to you all. As you see, 67,000 people will be diagnosed with pancreatic cancer in the US this year. The average rate of occurrence is about 13.7%, but for Black Americans, that rate is higher. Part of that has to do with potentially comorbidities that come with the disease, as diabetes has come up. There are a lot of comorbidities that should be explored with you and your doctor. We know that the 5-year survival rate is about 13%. This has climbed up in the last 10 years, and we're hopeful that with the energy and effort of Let's Win and the medical community, we can further increase this number over the next 5 years. If we go to the next slide, we can talk about where the pancreas is, right? It's hidden underneath a lot of layers of other organs, and that is why oftentimes the symptoms are a bit mysterious, right? Sometimes people talk about having back pain. Sometimes it manifests in other ways. Jaundice was how it manifested with my mom. So there are a lot of unexpected ways where this disease can manifest itself and the symptoms can come up, and sometimes they don't come up. So I think it's really important to talk about early screening like we are today, and always, look to get those questions answered from your doctor if you have any. So if we go to the next slide, would like to introduce Dr. Raymond Wadlow and patient advocate Andy Lyons, who will be leading the discussion today. Should Dr. Ray Wadlow should be.
Can you hear me, Juan?
Yes. Hey.
Okay, great. Thanks. Thanks so much. Sorry, I wasn't sure if I was supposed to just
all good. Your
jump
video's
in.
not on. Oh, there we are.
There we go.
Now,
Okay.
now we're rocking.
Well, thanks, Juan. Thanks, Cindy and Marcella, for inviting me to participate today. I'm really thrilled to be here and to have an opportunity to speak a little bit about pancreatic cancer and what we're doing in the screening and early detection community. So as the slide indicates, it is important to understand that pancreatic cancer cases are on the rise, and there are several major risk factor categories for pancreatic cancer. The predominant risk factor is something that we really can't do anything about, and that's aging. Although early onset pancreatic cancer is increasing, the most common age of diagnosis for pancreatic cancer is between the ages of 60 and 80, average age around 70. There are modifiable lifestyle-related behavioral risk factors as well. Smoking has been estimated to be responsible for as many as 30% of pancreatic cancers, and the risk is related to the amount smoked. The average smoker has a 50% increase in their risk of pancreatic cancer, or a relative risk of 1.5. And we know that smoking cessation also reduces risk over time, such that 10 to 15 years after stopping smoking, risk begins to revert back to the same as for non-smokers. And if we could eliminate all smoking in this country, it's been estimated that we could get rid of I guess, comparable to what I said at the beginning, 25 to 30% of US deaths from pancreatic cancer. Beyond smoking, we know that obesity and reduced physical activity also are associated with an increased risk of pancreatic cancer. There are data showing that a BMI greater than 30 is associated with a 70% increased risk compared to a BMI less than 23. And conversely, physical activity is associated with reduced risk. A healthy diet that's rich in fruits, vegetables, complex carbohydrates, and polyunsaturated fats is associated with a reduced risk of pancreatic cancer. And then alcohol, we know that a lot of the alcohol data are confounded by smoking, but heavy alcohol use has been associated with an increased risk of pancreatic cancer as well. And certainly individuals who suffer from alcohol-related pancreatitis are at increased risk of pancreatic cancer. I'll go to the next slide. Yeah, there are disease-related factors as well. The relationship between diabetes and pancreatic cancer is complex. Long-standing type 2 diabetes is associated with roughly double the risk of pancreatic cancer. There are also good data showing that a new diagnosis of diabetes, especially in a thin, older adult, can herald a diagnosis of pancreatic cancer as well. With regard to pancreatitis, I mentioned alcohol-related pancreatitis, but there is also a disease of hereditary pancreatitis, and we know that those individuals have as much as a 4 to 5% risk of pancreatic cancer over 20 years. And the rationale, the reason for that is pancreatitis is associated with chronic inflammation of the pancreas, and that chronic inflammation stimulates the development of mutations in early cancers. And then finally, pancreatic cysts, which are very, very common, often incidentally discovered, are pre-malignant, although the average pancreatic cyst has a very, very low likelihood of becoming cancerous. These cysts need to be monitored. I sort of liken them to moles. The vast majority of moles on our skin are not going to become melanoma, but it's possible, so they all need to be watched. Of course, with pancreatic cysts, it's more difficult to monitor than with skin exams. And what we are looking for in the monitoring of pancreatic cysts are size increase, especially greater than 3 centimeters, the association between a cyst and the main pancreatic duct, and then finally the involvement of a solid component to the cyst. If it's not just a simple cyst, those are all warning signals that a pancreatic cyst may be becoming malignant and needs possible surgery. Next slide, please. In terms of early detection and screening, it was mentioned at the beginning that there is no easy screening test for pancreatic cancer, and we'll talk about that a little bit more. But we are engaged in screening programs with the best tests that we have, and we're focused on individuals at higher than average risk. So those are divided into 2 major categories. One is an entity that we call familial pancreatic cancer. And really, technically speaking, those are families where there's no identifiable genetic mutation. But if an individual has a family history of pancreatic cancer in at least a first-degree relative, who in turn has a family history of pancreatic cancer in at least one first-degree relative. So a parent and a grandparent, a parent and an uncle or aunt on the same side, or certainly 2 first-degree relatives, a parent and a sibling would qualify as familial pancreatic cancer. And even when genetic testing is negative, we know that there can be a substantially increased risk of pancreatic cancer. And the biology, the genetic, and the combination of genetic and environmental factors that may lead to that increased risk is still an active area of investigation. There are also known genetic mutations that are associated with an increased risk of pancreatic cancer, and some of those, the most common ones are listed here, and they include BRCA1 and 2, which are perhaps better well known for their association with breast and ovarian cancer, but both of those genes, when mutated, increase the risk of pancreatic cancer. PALB2, which for those of you that don't know, stands for partner and localizer of BRCA2. So it's a gene that's very closely involved with BRCA2 that when mutated in families increases risk of pancreatic cancer. CDKN2A is something that when mutated leads to familial multiple mole and melanoma syndrome, but also is associated with an increased risk of pancreatic cancer. And then Lynch syndrome, which involve mutations in different genes, most commonly MLH1, MSH2, and MSH6. PMS2 is another one. Those genes, when mutated, most commonly are associated with colorectal, endometrial cancer, but in some families are associated with pancreatic cancer. And there are others as well. So this is an area of evolution and expanding knowledge. But when these gene mutations are identified in families, they increase the risk of pancreatic cancer and make those individuals candidates for early detection programs. And at the bottom, asterisk, that only 10 to 20% of pancreatic cancers are associated with known mutations. But there is a recommendation now that everybody with pancreatic cancer, regardless of family history, undergo genetic testing so that we can identify these mutations when present and then test their family members. So when we talk about screening, question number one is what qualifies you for screening? A lot of people have this question if they have a family history of pancreatic cancer. Well, we talked about the definition of familial pancreatic cancer. So right now, in the absence of a gene mutation, a single family member with pancreatic cancer, unless that individual is younger than age 45 to 50, doesn't meet the criteria for screening. So a single family member who was diagnosed at an older age with pancreatic cancer, if their genetic testing was negative, or if they weren't able to be tested, but your genetic testing is negative, then right now we're not recommending screening for those individuals. And part of that, again, as has been alluded to, is because until we get more cost-effective screening tests, it's relatively difficult to screen. What tests do you undergo? The two tests that we use for screening right now are MRI of the abdomen, sometimes also called MRCP, which is a specialized MRI scan of the pancreas and the biliary tract system, and then endoscopic ultrasound, where a gastroenterologist with specialized training in endoscopic ultrasound will put a camera down into the stomach, and then in addition, put an ultrasound probe down, which allows the endoscopist to look through the wall of the stomach with ultrasound at the pancreas. And then if there's a suspicious lesion, to even biopsy that lesion. So surveillance programs exist, and the typical screening program involves alternating the use of these two tests. So we typically get one year and the other the next year. So MRI followed by EUS, endoscopic ultrasound, back and forth we go. The tests have different strengths and weaknesses, and so we think this is the best approach to longitudinal comprehensive screening. And generally, we begin screening in high-risk populations in the age, we don't have total consensus, but usually between 45 and 50, or 10 years younger than the earliest age of diagnosis in the family. And then finally, the last question on the slide, should you get genetic testing? The answer is, if you have a family history of pancreatic cancer in a first or second degree relative, certainly, and we're not aware if they had genetic testing or not, then you should get genetic testing. Ideally, again, we're testing individuals with cancer because if we can eliminate the possibility of a known gene mutation in those individuals, at least for the time being, we recommend there's no need to do genetic testing of their first degree relatives. But many people have family members who unfortunately were diagnosed and passed away without genetic testing. And therefore, we do recommend testing for all of their first degree relatives. The main surveillance programs around the country are focused in sites of expertise around the country. We're part of one consortium, the Pancreatic Cancer Early Detection Consortium. There are others as well. So fortunately, more and more people have access to screening programs within driving distance of where they live. So Juan, I'll turn it back over to you. Do you want to introduce Andy?
If we could bring back Andy Lyons, please. He is someone who has been an amazing advocate, not just within the Let's Win community, but at large. and he's been gracious enough to share his story with all of us, and the many family members that he's unfortunately lost to pancreatic cancer. So I'll turn it over to Andy to tell you a little bit about his story and how he has pushed advocacy within his own journey.
Yes, I am gracious to be here. I'm excited to be here. And this is what I've always wanted to do. My story is, it's pretty compelling. Where do I start? My grandmother died of pancreatic cancer a long time ago. And then one of her sisters did, and maybe another sister. And then my mother died of pancreatic cancer in 1986. Her twin sister died a couple of years later. Their brother died a couple of years after that. And my brother died of pancreatic cancer in 2000. Dumb old me, cancer's cancer. I started putting the pieces together. It's like, guess what? I bet it's coming to you. So my brother and I, the last couple of days he was alive, figured it was time to get tested and let's do this. I live in Des Moines, Iowa. And, this was 2000. And, I was new to the cancer world, so I don't really know what was going on. I just figured cancer was cancer. And so I started seeing an oncologist here and doing an annual MRI and CAT scan and then meet with him. And I realized after the third year, it's like, this isn't the guy for me. I just kind of spinning my wheels, and no offense to him, but it wasn't, I knew it wasn't working for me. So I got home and got online and found a pancreatic cancer specialist in Omaha, Nebraska, which is like 2.5 hours from my home, doctor named Randy Brand. And his nurse asked why I was calling, and I told her, and said, this is a match made in heaven. He's a perfect one for you, and I think you're a perfect patient for him. She said, not only is he a specialist in pancreatic cancer, but he's doing research into familial pancreatic cancer. I said, that's awesome. Can I make an appointment? He said, well, I got some good news and some bad news. He's the guy for you. The bad news is he just moved to Chicago. Whatever, what's a 5-hour drive to save my life? So I called, and like a half hour later, and he picked up the phone and said, is this Andy? I'm gonna start crying. Told him the situation. He had me come to Northwestern University. I had to be interviewed to be part of his program, and he showed up and had a notebook like this thick, questions that he had to ask me. And the first question was, do you have a family history of pancreatic cancer? I do. The second question is, do you have any Eastern European Jewish heritage? I do. He closed the notebook, and I became part of his study. So that started 23 years of annual ultrasound endoscopies. Oh, and after 5 years in Chicago, he said, hey, I'm moving to Pittsburgh. Oh, fine, whatever, let's go. So I was continuing going every year, and everything was fine, no big deal. The reality was it just didn't seem possible. And then in 2021, he came in after my ultrasound endoscopy and said, you have cancer. It's the quietest I've ever been in my whole life. It was just unbelievable. And it was a perfect place to be. He said, what are your plans? Traveling Des Moines to Pittsburgh. And that year we had driven because we were going to go to the Great Smoky Mountains afterwards. He said, can you be here in 2 days in meeting with a surgical oncologist? And I said, well, of course. I mean, what is the most important thing going on now? Met with him. They somehow got me into surgery 10 days later. Actually, there was another doctor who I had talked to. Oh, and they were tickled. Let's talk about being tickled, pancreatic cancer. They said since the tumor was just starting, I was eligible to have robotic surgery rather than the whole split open Whipple, which was interesting. The doctor said that his assistant would take care of it, and he knows more about it. He was a young guy. I was a little apprehensive. I said, but I've talked to you and I would like to have you do the surgery. He said, well, I don't have any openings for 6 weeks. And quite frankly, I think it could be too late. 10 days sounds pretty good. So we drove home from Pittsburgh as fast as we could. No parking ticket or no speeding tickets. 10 days later, I had surgery. 5 days in the hospital. This was right around Thanksgiving and my birthday. We went to Dr. Brand's house with his whole family for Thanksgiving, which was just great. We have just a wonderful, wonderful relationship. And then the surgery went well. And then I came home and had 12 rounds of chemo. And that was, oh my gosh, I got out of chemo, or the chemo bar, as I called it, in 2022, I guess. And that was, seems like a lifetime ago. I'm cancer free. I try to spread the word about this horrible disease as much as I can. Just the early detection, it saved my life. And it was just, everyone should do it, you know. But anyway, so long story short, I'm a pancreatic cancer survivor. I used to say I'm a cancer survivor, but no, I'm a pancreatic cancer survivor. So, and I'm just thrilled with being part of this project and everything that everything you guys do. It's great.
Yeah, we're so grateful to have you, Andy. And I know this is a very vulnerable and challenging story to tell, but in the end, uplifting. So we're really grateful that you were here to share that with everyone. And if we go to the next slide, we can invite Dr. Ray Wadlow back just to do some Q&A. But yeah, if you all could please, I know we have some questions populating in, but if you all could please drop any questions you have in the chat, and we will direct them to Raymond and Andy. But starting with the first question we have from Roger, and this is directed to Dr. Wadlow. A study was just published that shows stress is a risk factor in pancreatic cancer. Comments on this or any lifestyle factors like a highly processed carb diet?
Right. Thanks for the question. So there are solid epidemiologic data, as I mentioned, linking a Western pattern diet that's high in processed foods, simple sugars and carbohydrates with not just pancreatic cancer, but other GI malignancies, I believe breast cancer as well, of course, insulin resistance, diabetes, and heart disease, possibly through obesity. The data, I just was able to take a brief look at the link you sent, Roger. The data sort of identifying the precise metabolic pathways is still an area of active investigation. That article in Science was from mouse models, it looks like, predominantly. So there's a long way to go toward before we know precisely what the actual molecular mechanisms are that link, for example, stress with cancer development. And then, of course, the goal beyond that would be to design therapeutics, right? Since we're never going to be able to fully eliminate stress from our lives, ways to control stress that are behavioral, and then obviously, if there are pharmaceutical ways, of course, that's only one potential way to leverage that information. So early days still, but those studies are very promising and ongoing. Thanks for the question.
Next question we have from Meredith, and thank you for your question. How do you find centers or studies that do screenings? I have only had one family member die of pancreatic cancer, and I do not think that will allow me to qualify for screenings at most places. I will start before passing it off to Dr. Wadlow to mention that we do have a doctor finder and clinical trial finder on our site. So definitely use Let's Win as a resource, but we'll pass it off to Dr. Wadlow to add further clarification there.
Yeah, so the first thing I'd say, Meredith, is that if your family member did not have known genetic testing with a negative test result, then you should consider getting testing yourself. And I'm not sure how closely that individual was related to you, but certainly if they were a first or second degree relative, you should have genetic testing. If your genetic testing is negative, then you're right. Absent a family history more extensive than a single family member, right now, we wouldn't recommend screening unless, as I said, that family member was younger than age 50 at diagnosis. In terms of talking this through a little bit, because it is a field in evolution, right? There are a lot of unanswered questions here. And so I think, as we develop more scalable, cost-effective screening solutions, we may ultimately, hopefully, be recommending screening not just to people with lesser degrees of family history, but maybe everybody once they get to be a certain age. But right now we're not. But to have that conversation and to stay apprised, of course, there are opportunities like these and invaluable platforms like Let's Win. In terms of finding an actual doctor to speak to, the Precede, just like the word Precede Consortium, has a public-facing website where you can identify the Precede site closest to where you live. And there are other places that are doing screening as well. There's a lot of overlap between the Precede Consortium and what's called the CAPS Consortium, CAPS, for cancer of the pancreas screening. But that's where I would start.
Awesome. Thank you, Dr. Wadlow. We have another question. Is screening recommended if my paternal grandmother died of pancreatic cancer at 78, no genetic testing, and I have a BRCA1 mutation from my maternal line?
That's a great question. That is a bit of a gray area. BRCA1 is associated, as I mentioned, with an increased risk of pancreatic cancer, although it is less than BRCA2. Right now, for BRCA1 gene mutation carriers with no family history of pancreatic cancer, and I realize that's not you, generally we are not recommending routine screening. It's not to say that some people don't choose to have it, but right now the guidelines for BRCA1 mutations, in contrast to BRCA2, are to not screen absent a family history. When there is a family history in a first or second degree relative, including your paternal grandmother, that does change things. I think especially if there may be reason to believe that that's the side of the family from which the BRCA mutation came, although even if it's the opposite side of the family, I think in the presence of a first or second degree relative and a low penetrance gene mutation like BRCA1, the standard answer would be to recommend screening once you're age 50.
Awesome. Thank you, Dr. Wadlow. We have a question for Andy. First and foremost, you are truly a walking miracle. After everything you've been through, what changes have you made to your lifestyle, if any?
Wow, walking miracle. I just did what needed to be done. I mean, and if it can help other people, and that was my whole goal of going through this whole process. Yeah, I didn't want to die, but there's a gene in here that maybe can save some lives. They haven't found it yet, and I'm going to keep going back to Pittsburgh every year until they do find it. And then I have an ultrasoundist for old time's sake. No, not really. I'm continuing with the screening and MRIs. Again, it's a 6-month thing. Hopefully they'll find the gene sometime. But has my life changed? It's such an interesting time. I was a commercial photographer, and it was just COVID was coming in, and when I was right before I was diagnosed, and I had a rotator, whatever. I've always approached life rather lightheartedly, as I did, with this cancer journey too. Positive attitude is everything. I don't really know that my lifestyle has changed that much. I remain active. I kind of a healthy eater, but not terribly healthy. My oncologist said, or the surgical oncologist said, no hot dogs for you. What? It's my favorite food. I'm just trying to learn more about the disease. I have friends who are going through this too. They know so much scientific data about it. Me, I just, they said, well, how was chemo? I laid there and went, it was, I asked questions, but, I was in great hands and just put my faith in all of them. Is that answering any of your questions? I could ramble on forever, but I've just noticed since 2.5 years out of chemo, I'm starting to get to be myself again. I mean, not necessarily my old self, but similar to my old self. But
Can you expand on that, Andy, a little bit, just for the audience? I think that would be really helpful. I know that
say
the
that
implication.
again.
If you could expand on that a little bit, Andy, being yourself again. I know
Sure.
that the chemo can, there's brain fog and different things that can happen with chemo. So I think it's useful for people to hear about that and coming out of the experience with chemo.
Yeah, absolutely. I mean, chemo brain was a real thing. We used to joke about it, and then it hit. Talking about a fog, it was challenging, to say the least. It was hard to, my attention span isn't so great anyway, was much worse then. And then the neuropathy in my hands and feet, and I still have it in my feet, and I want it gone. And so I'm doing all kinds of things. And it just takes time. I talked to Dr. Brand about it. And he said, figure out in about 3 years. I've asked other providers, and it's something that they must teach you guys in medical school in like the second year. So how long is it going to last? They do the shrug. I've tried everything, but being lucid again, having creativity back again, I'm just starting to feel good. It's not the old me, it's a new me, and I think it's better.
Awesome.
I don't know if that answers your question, but
yeah, thank you. That's a great answer, and a lot of love from Andy in the chat. Someone else mentioned, thank you for being so vulnerable and sharing your story, Andy. It is tremendous that in spite of everything you've been through, you still have such a good attitude and want to help others too. So,
well, that's very nice to say. This, I think, is what I was meant to do. I mean, I think my family got this disease, so what are you going to do with it? Well, my brother didn't get a chance, and my brother was diagnosed. He was in international marketing public relations and based in Hong Kong, and he traveled all the time. And in a 30-day period, he lost 30 pounds and wasn't quite sure what was going on. And he was diagnosed with pancreatic cancer. After we met in Chicago because he was coming for a second opinion, and the oncologist said, 6, maybe 9 weeks.
wow.
It's horrifying, just horrifying. And just to watch that. Anyway, but anyway, thank you. I mean, I appreciate the compliments, but this is, if we can save some lives here, let's do that.
And to that point, Andy, and this one's actually for both of you, how do we encourage reluctant relatives or friends who are at risk for pancreatic cancer?
Well, I wish I knew, because I have first cousins that just aren't interested at all. We don't want to know. Why would we want to know? Because maybe it'll save your life, and how about your grandchildren too? But we fight all the time, and they don't get it, and I just don't know what to do. So
yeah, I can add to that. I think that there's a lot of historical nihilism about this disease. And the data are the data. 5-year survival of 13% is still, although it's going up, it's not a number that's going to obviously we have a lot of work to do. But I can address that question. There's a couple other questions about interval of screening, and what about the risk of cancer being detected between screening tests. I think the honest answer is that, yeah, I mean, we're still, as I have said several times, we're still learning. And one of the major goal, the primary goal of the PROCEED consortium is to really prove at a large scale internationally that screening and early detection programs save lives. That still needs to be proven, but the early data are very promising. There are published series showing that screen detected cancers have 5-year survivals, in some cases in excess of 80%, which is much, much better than even early stage symptomatic cancers, where historically 5-year survival was more like 20%. So there are clear data suggesting that the identification of a pancreatic cancer prior to the onset of symptoms gives you a much better chance of cure with surgery, and oftentimes chemotherapy as well. In terms of screening, the possibility of cancers being diagnosed between annual screening tests, yeah, I mean, that can happen. And we are continuing to work to try to identify higher risk groups, right? Because not all risk is the same, who need more frequent screening. So there are some less common gene mutations like CDKN2A, which I mentioned, or STK11, which is associated with something called Putz-Jaeger syndrome, which have much higher risks of pancreatic cancer. And those individuals are often screened every 6 months instead of every 12 months. But this is an area that's still being worked out. So great questions.
Yeah, and to that point of communities that might be higher impacted, there's one specifically among the Hispanic community that has a higher incidence around diabetes. Is there anything that you would recommend to that community without causing alarm for them to do in terms of pancreatic cancer?
I think a lot of it is just education and awareness, right? So increasing public education about not just pancreatic cancer, but the efficacy of cancer screenings in general, the efficacy of blood glucose control for people with diabetes or diabetes prevention, combating the nihilism that I alluded to a moment ago, that we really can do something about this disease when we work together. And then encouraging people to talk about this with their families. I think another thing we've been reluctant to do, maybe more so in some communities than others, although I think it's fairly much a human common denominator. It's not a lot of fun to talk about cancer, and people don't want to talk about it. But I think we have to, and we have to know our family history. We have to encourage the kind of vulnerability and open dialogue that Andy's modeling for us, so that we can learn from each other. And when you know your family history and you're educated and aware, you're more likely to leverage the resources that are available, and that could potentially save your life.
Well, and now these days, providers are talking to each other, researchers are talking to each other. When I started, it really wasn't that way. And, growing up, hell, even into my 50s, we didn't talk about cancer that much. We maybe whispered it a little bit. We didn't want to talk about cancer. Hell, I'm yelling it all over the place so people will know it's too important not to, but it's coming out in the open now. I was at a presentation not too long ago, and it was the weirdest thing to hear a doctor say, you know what, if you're going to get cancer, this is the time to get it, because the research is so much better and early detection is so much better. Oh, and early detection. So when they found my tumor, everyone says, so what stage was it? It was like stage, I like to say stage. It was just starting. It was just this little guy. It's like an alien, but it was dying to get out and ravage me, but it didn't get a chance. So many other people are diagnosed at stage 3 and 4, and it's I'm kind of passionate about early detection.
Yes.
So sorry.
Super important. Thank you, Andy, for emphasizing that. We have another question about time frame between testing, Dr. Wadlow. Coming from Holly, she said she has so many questions. Her father passed away 21 years ago at the age of 67, and his was deemed environmental. Her 54-year-old sister was diagnosed in October and does not carry the gene. She also does not carry the gene, but she is very concerned about the time frame between testing. What would your best recommendation be?
Right. Yeah. I mean, it's hard to give specific medical advice without really having a full medical conversation and going over all the nuances. But I think, as I had mentioned, there are instances where more frequent screening is appropriate, whether it's a greater number of family members or one of the higher penetrance genes, or perhaps, a mildly concerning finding on a scan, the appearance of a new cystic lesion, or where one of the areas of research within PRECEDE is using artificial intelligence to discover things that elude sort of normal human eyes, like small changes in the diameter of the pancreatic duct or other things that would say, okay, maybe this was on an MRI, maybe we should do an EUS now as well, instead of waiting a year, or maybe we should do another MRI in 6 months. So one of the things that's really important about these screening programs is that they're not just offered in isolation, that they really are in places where all of the the multidisciplinary pieces are in place to then act on any information, right? So I'm a medical oncologist. I don't do pancreatic surgery. I don't do EUS. I'm not a radiologist. I don't primarily read these MRIs. But what I have is a community of people working with me so that when I have a question or there's a concern or I need to get the input from my colleagues, I have conferences and the ability to sort of review these cases multiple times per week. So I know that's not a straightforward answer to your question, but I would say some of it is we don't know. And some of it is, talk to your team and make sure that they're addressing these concerns, that they're going over them with you. And where there's uncertainty, there may be a rationale to have a conversation about doing something that's not standard.
And to that point, Dr. Wadlow, if you're facing, some roadblocks in your journey and you have these concerns, like what is your bet? What would your recommendation be for course of action with someone who, similar to Holly's situation, could have other family members impacted, but we maybe don't have the tests yet to identify things that they might have?
Well, I mean, again, I think platforms like Let's Win are just tremendous assets to the community, right? They enable the kind of networking between patients, providers, loved ones, to really sort of network and work together. So I would say reach out, communicate, ask questions, find people. You're not alone. Other people have had these questions as well. There are probably multiple other people who are in situations very similar to your precise situation, given the number of people that have been impacted by this disease. So that would be my number one piece of advice.
Awesome. Thank you,
Well,
Doctor.
and also with the Let's Win with the directory of providers, if you're not happy, get a second opinion.
Switch. Yeah. Totally.
It's not, I mean, I was I didn't have to do that with Dr. Brand, but the doc before I did, and I was apprehensive about doing it. I don't want to hurt his feelings. What the hell? My life depended on it. And it took a while for that to sink in. And I encourage, all my friends and people I know who are going through this, do that. If you're happy with what you got, fine. If you're not, don't settle. Lives do depend on it. So, and to have that kind of directory available, gee, that was available. When I was your age, that wasn't available. So it's nice to have those resources. So
that's great. Yeah, I completely agree with that, Andy. And kind of to my earlier point of being your own advocate, don't settle for, the care that's being given to you. If you feel like you're not getting the answers you need, ask further, ask for a second, third opinion. I think that there's no shortage of options nowadays with resources that are available, including Let's Win. So going to another question, we have about 10 minutes, everyone. So if you have any additional questions, please drop them in the chat. But we have one from Annette. Are you excited about the blood test screening being developed by OHSU in Portland? Is there any promising data there, Dr. Wadlow?
Yeah, I mean, I'm not going to speak to specific blood tests, but there's a lot of work going on. Obviously, the ability to screen or introduce blood testing into early detection programs is going to be a major step forward. There are lots still of unanswered questions related to test performance. Obviously, if you're going to use a blood test, you want to make sure that the false negative rate is very low. You also want a very low false positive rate because of the difficulties of diagnosing pancreatic cancer using imaging. You can imagine a scenario where a blood test suggests the presence of a very small microscopic cancer, but if you can't see it, that's a conundrum that needs to be thought through very carefully. So yes, tremendous excitement. These tests are coming. They're coming soon. There's a lot of great work being done, but still a lot of work to do.
Thank you.
But it's starting.
Yeah.
It's ongoing. It's more than starting. Like there are lots of publications and meeting presentations already on the efficacy of some of these tests, but the tests need to continue to be validated within large, well-conducted clinical trials.
Which I will then plug again. Let's Win's Clinical Trial Finder. Please use that as a resource. We've invested a lot of resources as an organization in that, and definitely encourage anyone who is looking for clinical trials to look to Let's Win's website. Our next question we have, how do you find centers or studies that do the screenings? I kind of led that question a little bit, but Dr. Wadlow, Andy, if you've only had one family member die of pancreatic cancer, do you think that will allow someone to qualify for the study?
Again, I think the first thing is, if you had a family member who is deceased and you know that they had pancreatic cancer, you're suspicious they had pancreatic cancer, but they did not have genetic testing, then you yourself should see a genetic counselor and have genetic testing. I think that's the first thing that we tell people that are referred to our center here. In fact, I have them see one of my colleagues in genetic counseling before they see me, because that information is so important in informing decisions about screening. So that's the first thing to do. And then if the test is positive, that obviously will send you down one path. If there's not a mutation, then it really becomes a question of, is there more family history, or how well annotated is your family history, right? I mean, family histories are all over the map in terms of, are people adopted? They have no idea what their family history is, or are their family, they may not really know. And so that level of detail also is truly important in making an informed decision about screening.
Thank you, Dr. Wadlow. As we look at screening and the timetables for screening, do you think that there's an appropriate timetable that's standard of care in terms of screening if someone has a family member that has been impacted?
I think the most common recommendation, which is supported by the NCCN recommendations, which are the National Comprehensive Cancer Network recommendations that we use, is to begin screening at age 50 or 10 years before the earliest age of diagnosis in the family, if you meet the classification criteria for screening, which again are this familial pancreatic cancer criteria or one of the gene mutations. So there are details, but if you qualify for screening, the age to start is 50, or again, if you had a family member that was younger than 60, then you would start 10 years before their age of diagnosis.
Got it. Thank you. Awesome. And then I think we covered part of this, but in terms of finding the actual places to get screened, is that more about finding the right doctor to screen you? Is there a specific type of doctor that you should go to get the type of early detection screening, or is it anyone affiliated with pancreatic cancer, be it an oncologist or a surgical oncologist?
Yeah, good question. I don't think the type of doctor matters. I mean, there are a handful of us who are principal investigators within the PROCEED consortium that are medical oncologists, but more are surgical oncologists or gastroenterologists like Dr. Brand. What matters is, again, is it a center that has expertise and the infrastructure in place to appropriately counsel patients on all of the issues related to screening, to follow them over time, to ideally participate in research that will move the field forward, to work together with others, including other screening centers and patient advocacy groups like Let's Win. This is a community, and that's how we're going to make progress. So I think the best advice is to try to plug into that community somewhere. Unfortunately, it's getting easier and easier to do that.
Thank you. Open for any other questions in the chat if you have any. I know we're almost about time. I'll leave it open to Okay, looks like no other questions. Well, thanks everyone for joining today's session. Of course, if you have any further questions that weren't answered today, please go to the Let's Win website. We've just undergone a full revamp of the site to make it a lot more easy to use and easy to identify yourself within that journey, whether it's risks and symptoms, screening and early detection, who should be screened, and also screening programs to save high-risk people. We also have a newsletter in English and Spanish, so please I encourage you to use Let's Win as a resource. It is there for you, and the community is there behind it to support you. So thank you all for today's session and appreciate everyone's participation. Particularly thank you to Dr. Wadlow and Andy for the informative session. Now I'll pass it back to Cindy to say thank you.
I'm going to first thank you and Dr. Wadlow and Andy. First of all, Juan, you can be our spokesperson. Thank you for being such a great cheerleader for not only Let's Win, but the Let's Win family, which is the entire pancreatic cancer community, to really help patients get the resources they need. And Dr. Wadlow and Andy, your story is really, really inspiring. And it is so important to hear your story and to learn from you and what you've done. So thank you for being here. And Dr. Wadlow, you're a rock star. Thank you for helping us protect and save lives. I hope everybody will join us. Marcella, this is always a treat to partner with you. So thank you. I hope everybody will join us at our next webinar on June 11th, where we will talk about the latest research. So thank you and have a great day. And just one more thing. We started something last year that really was well received. We had one of our webinars in Spanish, and we plan to do that in the fall again this year.